Welcome to everyone who's joining the webinar today. We're going to give everyone just a couple of minutes to log in and join the session, and then we'll get started. Welcome everyone, and thanks so much for joining us today for the sixth of our series of talks on thinking about migrations in global, interdisciplinary, multi-species terms. We're really excited to have you here with us today to hear the talk on immigration, healthcare, and the coronavirus crisis. And I'm going to quickly hand it over to Rachel Riedel to introduce today's speakers. Rachel is the director of the Einaudi Center and is working closely with our team on the migrations initiative that this series is a part of. Thanks, Rachel.
Thank you, Eleanor. I'm so pleased to be here as the director of the Einaudi Center for International Studies, and particularly to be a partner in the Global Grand Challenge of the Migrations Initiative, and particularly in this critical topic as we address the problems of our world on the move. As a part of the Migrations Initiative, we're working together with our two faculty fellows at the Einaudi Center who are presenting here today, Gunisha Kaur of Weill Cornell Medicine and Steve Yale-Loehr of Cornell Law School. Dr. Kaur is an anesthesiologist specializing in human rights research. She serves as the medical director of the Weill Cornell Center for Human Rights, and she is also part of the Global Health Initiative and the program director of Anesthesiology Global Health Fellowship at Weill Cornell. Dr. Kaur's research interests focus on displaced populations such as migrants, refugees, and asylum seekers. Steve Yale-Loehr is a professor of immigration law practice. He's a professor of immigration law practice and an internationally renowned lawyer in immigration law practicing for over 35 years. He's the co-author of Immigration Law and Procedure, the leading 21-volume treatise on U.S. immigration law. He also teaches immigration and asylum law courses at the law school and is counsel at Miller Meyer in Ithaca, New York. Together with our postdoctoral fellow, Eleanor Paintner, who you've just heard from, we are organizing a number of related initiatives to advance the migrations approach of transdisciplinary multi-species perspectives. And these variety of activities include a works in progress colloquium, that we include people to present, that we invite people to present in, a migrations minor, and a summer institute for graduate students and early career faculty, as well as a number of cross-campus research collaborations. I think this team really exemplifies our multidisciplinary approach with a combination here just exemplified today in law, health, and humanities and social sciences. So today, Gunisha and Steve will be telling us more about their Migrations Initiative research project surrounding refugee and immigrant health. Thank you so much for joining us today.
Thank you so much for having us. I'm Gunisha, and I'm really excited to be here with Steve to talk about the Migrations Initiative and our research project. Today, we're going to focus on immigration, healthcare, and the coronavirus pandemic, and really combine those medical and legal perspectives. Steve and I will go back and forth between the slides rather than presenting sequentially. What we know from prior pandemics is that natural disasters reveal fault lines: socioeconomic, health, environmental, security. The 2015 Ebola outbreak and pandemic is a really great example of how weakened infrastructure is revealed when natural disasters hit. Those three countries, Liberia, Sierra Leone, and Guinea, had some of the lowest healthcare infrastructure and investment in all of Africa, and that system really unraveled when Ebola hit. And that's exactly what's happening with this pandemic. So today we'll briefly cover medical legal aspects of healthcare for immigrants in this pandemic, and a little bit about what Cornell is doing to address some of these issues.
So here's an overview of our talk. As Gunisha already pointed out, we'll start with sort of an overview of medical legal aspects, then we'll focus on one particular new change called the public charge rule and how that's affecting immigrants who want to seek immigration and healthcare benefits. We'll talk a little bit more about that in more detail, and then we'll wrap up by talking about our own research project through the Migrations Initiative and what each of our institutions is doing. So Gunisha, why don't you tell us a little bit about the Migrations Initiative generally?
As background, the Migrations Initiative is part of the global grand challenge throughout Cornell University that focuses on research, teaching, and building for a world on the move. It's comprised of several faculty, fellows, postdoctoral students, undergraduates, and we study how living things, both plants, animals, humans, migrate from place to place on our planet, crossing borders, and the effects of those on each other. We have faculty from disciplines that cross law, medicine, architecture, ornithology, government, and more. And through the Einaudi Center for International Studies, Steve and I are the two faculty fellows who are leading the migrations lab.
So as part of the lab, Cornell has kindly funded various research projects. And Gunisha and I were able to receive funding from the Migrations Initiative to research the impact of new public benefits restrictions on immigrant patients at Weill Cornell Medicine in New York City. We'll talk more about our project and our research later in this presentation.
So our goals are really in line with the mission of the college, the idea of one Cornell across the three campuses, where we're harnessing the expertise of individuals across Cornell's campuses to create novel solutions to some of the most pressing and challenging issues of inequality of our time. So this is the framework through which we're operating today. Steve and I will present overlaying complicated interplay between the medical, legal aspects of healthcare for immigrants, how those challenges are amplified during COVID. There are many aspects that we could focus on, but today we'll cover disparities and inequalities in the context of COVID, the public charge rule, and then issues specific to refugees and asylum seekers. So here's what the data are telling us about racial and ethnic disparities. Geographic locations that reported data by race and ethnicity indicate that African Americans and Latinx individuals bear a disproportionate burden of COVID-19 related negative outcomes. So we've seen this in cities from Chicago to New York, where the rates of cases in African Americans are higher of COVID-19, as is the age-adjusted mortality. So it's not just that people are more likely to have COVID-19, but also that the outcomes, the negative outcomes, tend to be worse in those populations. Where data exist in other minority communities, such as American Indian communities, Alaska Natives, Pacific Islander populations, we see similar trends. This is, of course, a familiar concept to us. It's why documenting disparities in the larger communities, such as African American communities or Latinx communities, is so important and relevant. The disparities exist in smaller minority communities. We just may not have the numbers to demonstrate that. So what we see in those larger communities really can be extrapolated to the other communities. And of course, the underlying causes of disparities are really complex. They include the social and structural determinants of health, racism and discrimination, economic and educational disadvantages, healthcare access and inequality, amongst other biosocial factors. The most common explanations for the disproportionate burden of disease and morbidity outcomes involve two issues. First, minority populations have a disproportionate burden of underlying conditions such as diabetes, cardiovascular illness, asthma, or HIV. Second, minority and impoverished communities, people in urban settings, live in more crowded conditions, both in terms of neighborhood and in terms of household, and are more likely to be employed by public-facing occupations such as service or transportation, which have been deemed essential during this pandemic. And those occupations tend to prevent physical distancing. Of course, all of these explanations have to be considered in the context of systemic factors such as discrimination and the physiologic insult of chronic stress. For example, what is the physiological impact of loss of health insurance or an inequitable distribution of scarce testing and hospital resources, access to digital resources or devices, schooling, food insecurity, housing insecurity? The term weathering has been used in other communities and in other situations, particularly in racial discrimination, to describe advanced aging and bodily wear that's caused from fight or flight responses to external stressors, that chronic insult of stress. And weathering has been linked in turn to cardiovascular disease and diabetes, two of the conditions which are associated with an elevated risk of severe COVID-19. So imagine that you are already in an occupation that requires you to be public facing, you're in a more crowded household or community setting. You have underlying conditions such as hypertension or diabetes, and then you have chronic stress that overlays on that. It's understandable that those communities may face a disproportionate burden of mortality and morbidity from COVID-19. So what I'm describing here with racial and ethnic disparities is it directly parallel to what's happening in immigrant communities. Under the category of immigrants fall individuals such as legal immigrants, refugees, asylum seekers, and then undocumented immigrants. Baseline stressors that I described that racial and ethnic minority communities face, such as lack of housing or stress from policing or discrimination, is experienced by immigrant communities in a similar way. Particularly those of non-legal status, those immigrants are a uniquely vulnerable population. The Affordable Care Act excludes undocumented immigrants from coverage eligibility, meaning that 7.1 million undocumented immigrants lack health insurance. Many do not have primary care providers and lack English proficiency, which of course leaves them in a particularly vulnerable situation when we have this pandemic. We have strongly encouraged people not to go to emergency departments, which is typically where an undocumented individual may go for healthcare. So when they're excluded from those opportunities, there's an additional burden from this pandemic. Even low-risk patients benefit from speaking with a clinician, getting reassurance, discussing a plan of action. some of what we talk about as barriers to care in minority communities are amplified and worsened in immigrant communities. For example, telemedicine, which we've really converted to here at Weill Cornell. In the spring, we really converted almost every single visit to a virtual visit. That, of course, there's problems with minority communities accessing telemedicine, whether it's device or English language proficiency, but it's a unique problem for immigrants. For example, relying on telephone visits involving interpreters without the benefits of visual cues can be really problematic. Lack of digital access or ability to log on to a provider. And finally, fear of tracking by government agencies such as ICE. We've heard a lot about contact tracing in some states. That's being done by healthcare providers, such as Massachusetts, that's being done by healthcare providers. But in some places, it's being done by the police. So that's a really complex situation for an undocumented individual to have a public health intervention being done by law enforcement. As people are asked to shelter at home, this of course has an additional impact on undocumented immigrants, many of whom are in service industries such as restaurants or hotels or the informal economy. And worst possibly is that they'll be excluded from the social safety net. Relief packages such as paid leave benefits or direct cash benefits, immigrants and undocumented immigrants may not see those benefits. There's some data that indicates that nearly 5 million US born children who have undocumented immigrant parents might be impacted. One thing that we have to be mindful of is, and cautious of when we discuss disparities around minority communities, is that we have to include really rigorous granular data with multi-level modeling so that minority communities don't become a target as a result of our findings and our investigations. We don't want to sort of reinforce territorial stigmatization where resource-poor neighborhoods are thought to be comprised of poor people or of minorities or of foreigners who are already marginalized. We don't want to contribute to immigrant stigmatization where foreigners are thought to bring disease to the United States. As we unearth disparities, we must ensure that neighborhood-based or race-based or ethnicity-based or immigrant status-based stigma are not conflated with illness and don't lead to the blaming of communities or repressive surveillance or a decision by government or society to ignore or neglect these communities. All of those fears are really rooted in historical precedent. All of that has happened before. So we want to be really mindful when we're discussing minority communities not to reinforce that. What we don't want is the resultant narrative of COVID-19 to be that this is a problem of minorities or that this is a problem of immigrants or refugees, thereby leading to further discrimination. As anti-immigrant rhetoric really builds in the national discourse, we are really seeing a major threat to the community's physical and psychological health. In each of the past 3 years, hate crimes have increased substantially, and the violent nature of these crimes has also increased. So we also need to be aware of that biosocial impact and think about how we're framing the problems of COVID-19 and these communities. You know, if someone is uncertain of where they'll be employed, what their housing looks like, they're being threatened by ICE or external stressors, anti-immigrant rhetoric, what kind of stress might that result in? And how might we as a community or an academic institution really support those individuals? The news has been keeping up with the disparate impact of coronavirus on different populations, but we're not really covering what's happening with immigrants. And of course, there are many reasons why people don't seek care or why care may be extremely delayed or put off until things become critical. There is definitely a lack of trust in healthcare systems and healthcare providers, and that is also based on real history of using minority communities or immigrants as guinea pigs in studies. So that's really based in a real fear of healthcare systems and providers. There's the fear of cost, not just the cost that one might incur from being in the hospital or a procedure that has to happen, or the cost of an x-ray, for example, or lab tests, which can run hundreds or thousands of dollars, but also a fear of what the economic impact might be from not working. And not being able to support your family. Cultural or linguistic differences, multi-generational homes might trump and needs of those homes might trump the needs of an individual. Language barriers, especially when family members who might be able to assist in translation are not allowed in hospitals. And then a lack of insurance, a fear of deportation. So these kinds of things play into the healthcare system and how individuals, immigrants, are engaging in healthcare systems, and how that might be a feedback loop that worsens the morbidity and mortality from COVID-19. So with that, Steve will speak specifically about the public charge rule and share some practical guidance and understanding.
So as many of you know, the Trump administration has focused on immigration in its 3.5 years that it's been in power. And one think tank has estimated there have been over 400 immigration changes in the last 3.5 years. So immigrants have faced relentless attacks, threats to the Deferred Action for Childhood Arrivals program, raids by ICE agents, asylum restrictions, separation of families at the borders, and what we'll focus on in this talk, the tightening of the public charge rule. The public charge rule is just one example, and it's really the cumulative impact of all these policies that's greater than any one change. And on the public charge rule, as we'll see, fewer than 1% of immigrants may actually be impacted by the public charge rule. But because of fear over the rule, millions of immigrants have disenrolled themselves from public benefits to which they may be entitled, like Medicaid or housing assistance or food to their children through food stamps or school lunches. So there seems to be an effort by the administration to cause more mental anxiety for immigrants in the hopes that they'll either self-deport or that other immigrants won't come to the United States. So to help you understand our research project, I first need to educate you on what a public charge is. This is a concept in immigration law that's been around for 150 years. And basically, Congress does not want people in the United States who rely solely or largely on public benefits to survive. If you're that kind of person, then you're deemed to be a public charge. The immigration law does not define what a public charge is. And so the agencies have had to define the term. It is a concept, and it applies both to people coming into the United States, people applying for green cards outside the United States, and for people who are already here who are trying to get a green card. So the public charge has been around since the late 1800s. But the prior definition of public charge was fairly limited. It basically meant someone who was using cash benefits to maintain their income, or who was institutionalized for long-term care at government expense. So relatively few people were actually subject to the public charge rule. That all changed in February of this year when the Department of Homeland Security issued a new rule that expanded the definition of who might be a public charge, and therefore either inadmissible to the United States or deportable from the United States. It's a very complicated rule. As you can see there, they have to receive a specific public benefit for more than 12 months in the aggregate within any 36-month period. And they use a totality of the circumstances test to look in the future to see if they think you're more likely than not to become a public charge. That's a lot of lawyer lingo and doesn't really make sense to a lot of people. The biggest change in trying to put that into plain English is that the new rule includes more non-cash benefits. And we'll talk about what that means. But certainly the mere fact that the government now is expanding the concept of public charge caused fear and confusion among immigrants, as these headlines point out. And in our research study, we hope to educate doctors and others about what the new rules actually say, so that they in turn can educate immigrant patients about what they still are entitled to as public benefits. And we also hope to then also use this resources that we learn from immigrants themselves as to how they access information to help them make informed decisions through digital tools. Adding to the confusion about the public charge rule is that several lawsuits have been filed saying that this new public charge rule violates the immigration statute, that it's too vague to be applied inconsistently, that it is discriminatory. The lawsuits are continuing. So far, the courts have temporarily allowed the federal government to enforce the new public charge rule, but the litigation has not finished. So there's still a chance that the public charge rule could be stricken down. But in the meantime, people have to abide by it. And the mere fact of litigation is causing further anxiety and confusion. To try to summarize it, it applies both to what we call non-immigrants, people who are here temporarily, who want to extend their status here, who want to change their status, perhaps from being a student at Cornell to working after they graduate, and also to people who are trying to become what we call green card holders, lawful permanent residents, either inside or outside the United States. The public charge rule does not apply to certain categories of people. And some of those on these slides you recognize at least the names, like refugees and asylum seekers. Others are very specific, such as applicants under the Life Act, which is a specific statute enacted by Congress, or individuals granted relief under 3 other laws. So that also makes it confusing because not every immigrant is subject to the public charge rule. Here's a graphic that we've put together to try to help people understand if the public charge rule does or does not apply. If you are in one of the red circles, then the public charge rule does apply. If you're in one of the green circles, then the public charge rule does not apply to you. And then there's a gray circle. It says, well, sometimes it may apply to you. And again, that causes more confusion because it's confusing even for immigration lawyers to understand this or to explain this to their immigration clients, let alone trying to have a doctor who's trained in medicine try to explain this to immigrant patients. Here's another visual of some of the public benefits that are subject to the public charge rule. Most applicants are not eligible for these benefits anyway because of restrictions on the immigration law. The question is whether the government thinks you might access some of these benefits in the future. So for example, cash assistance is something that in New York is called safety net assistance or family assistance. That is a kind of thing that is subject to the public charge rule. At the federal level, there's something called the temporary assistance for needy families. That means that if you take that from the federal government, you are subject to the public charge rule. But there are other benefits that do not count toward making you inadmissible or deportable under the public charge rule. So for example, your kids can go to the National School Lunch Program. There are the health insurance program for children known as CHIP. There's Women, Infants, and Children program. There's Head Start programs. Most importantly for our research, there is an exception for pregnant women. If they qualify for Medicaid, they can see their doctor during pregnancy without worrying about public charge issues. And if they have insurance, they are also fine. And that's one of the things we're pointing out in our study for both doctors and immigrant patients. But many people don't know about this and they think any public benefit is going to get them deported, and so they don't want to engage in any kind of public benefit. The new rule does not have sort of a black and white test that if you accept a certain kind of benefit, you are automatically inadmissible or deportable. Rather, they look at whether you might use one of 12 benefits over a 3-year period. It's a balancing test. No one factor is outcome determinative. There are some factors that are heavily weighted negatively and others that are heavily weighted positively. But I cannot tell any individual client that they definitely are a public charge. And that is causing confusion for immigrants as well too. To add to this, we have the whole COVID crisis. The public charge rule came out in February before COVID really became a concern. by March, immigrants were asking me and Gunisha, well, what does COVID mean now, for example? If I have COVID, should I get health care or not? Can I access emergency Medicare if I'm undocumented and have coronavirus? If I go to a doctor's office, should I worry that immigration is going to come knocking at the door and put me into deportation proceedings? The quick answers to these questions are yes. If you can get health insurance now, you should. There's no type of health insurance other than federal Medicaid, and even under Medicaid, pregnant women and children and certain others are exempt, that counts for public charge purposes. There are healthcare programs that are not considered a public benefit for purposes of the public charge test. For example, in New York State, there's state Medicaid. That's fine. That's not subject to public charge. There's also something known as the essential plan. That's also not subject to public charge. Also, if you can access emergency Medicaid, those are not subject to Medicaid if you're applying for emergency medical conditions. And similarly, if you're undocumented, it's very unlikely that immigration is going to come knocking on the doctor's door. They have a policy, even under this administration, that they do not go to so-called sensitive locations, and hospitals are one of those sensitive locations. So patients should feel confident that they can see their doctor without ending up in deportation. Another cause for confusion is that the immigration agency, USCIS, known as U.S. Citizenship and Immigration Services, took a long time to come out with a policy guidance on whether immigrants could receive treatment or testing for COVID and whether that would apply toward the public charge determination. About a month after COVID really hit the United States, they finally came out with this policy statement that you see on the slide here that says they will not consider testing, treatment, or preventative care like a vaccine related to COVID to be part of the public charge determination. And that sounds good. But then the same policy goes on that says the rule requires the immigration agency to consider the receipt of certain cash and non-cash public benefits, including those that may be used to obtain testing or treatment for COVID-19 in a public charge determination. So the agency, even in its own supposedly clarifying guidance, just muddied the waters further. I'll talk a little bit about what the law school is doing generally regarding immigrants and public charge and COVID, and then Gunisha will talk about what she's doing at the medical school and more about our research project. We're doing 5 things here. We're certainly doing a lot of webinars. We did one in April and another one in July. Each of them had over 1,000 people nationwide to try to talk to individuals, healthcare providers, nonprofits, social service agencies about the impact of the new public charge rule and the impact of coronavirus on immigrants. We're also involved in litigation, both class actions on behalf of broad groups of people, especially detained immigrants in detention centers where they are at high risk of getting coronavirus, and in individual cases. We're advocating more generally by writing op-eds and others. We're working at an international level to make sure that immigrants around the world get basic treatment for COVID. And we're conducting research like the project that I'm doing with COVID. So with that, I'll turn it over to Gunisha to talk about what the Weill Cornell Center for Human Rights does generally and this specific project.
So I think what Steve is really describing is that, and the big takeaway here is that this is incredibly confusing and incredibly stressful for all of us. And then overlaying how complicated it is to understand the legal aspects of it, how the legal aspects play into the medical aspects, it creates a lot of stress. And that stress then plays into increased morbidity and mortality for our patients. So at Weill Cornell, we're doing a handful of different things, whatever we can, to help our immigrant patients and our immigrant populations. We're working very closely with the law school on several different projects, with Cornell Tech, with Department of Communications at Cornell, anybody who we think can, in that multidisciplinary way, really enhance the health of this population and decrease the stress that's associated with COVID-19. So I'll give a couple of examples of what we're doing. This is by no means an exhaustive list, but just to give you a sense of how one might be able to take the training that they have, the education that they have, and benefit immigrant populations or vulnerable populations more generally. So the Weill-Cornell Center for Human Rights is one example. This is a student-run clinic that is really run by our medical students from top to bottom. In the pre-COVID era, the students coordinated care for refugees and asylum seekers through pro bono forensic medical evaluations. This year, the clinic celebrates its 10-year anniversary, and the students in those 10 years have evaluated nearly 700 asylum seekers from all over the world. They have seeded 20 other clinics across the country at major academic medical centers and have trained over 400 professionals and 1,000 Weill-Cornell students to participate in asylum evaluations. So the power of these medical students to take their training, their knowledge, and really flip it into care for these vulnerable populations, I think is a huge inspiration. Amplifying the impact of these numbers, clients evaluated at the WCCHR have a rate of obtaining asylum of 95% as compared to the national average of about 35%. Next slide, Steve. So our clinic has evaluated people from 74 different countries, and we've really seen a global population of asylum seekers. Working together with the law school and the tech campus and Department of Communication, we've tried to create more programs for asylum seekers and individuals who are vulnerable in this time. We're investigating, for example, how technology might be utilized to convey knowledge to immigrants about their rights to access health or other public benefits. We're creating an understanding of how technology can be used to bridge the gap between asylum seekers' needs and available resources. And this again is through the Department of Communication, and we're using our knowledge in the law and of what the medical needs are to kind of bring that all together and convey that to individuals. We're focused on comprehending information literacy. How do asylum seekers engage and evaluate available healthcare information online? How might telemedicine affect individuals? How might the fear of ICE, even if hospitals are safe zones, how might their understanding of technology, the role of technology, both positive and benefit, impact the way that they might engage with some of the knowledge that we would be able to provide them? And finally, creating digital tools and resources to increase participation in health systems by asylum seekers. So can we provide resources, given the skills that our communications folks have, are individuals who really specialize in digital tools and technology? Can we increase participation in health systems and decrease some of those gaps in care and decrease the difference in morbidity and mortality for these populations? So the group that we're really hoping to help is the global population of asylum seekers. It's people from all over the world, both adults and children. Beyond the medical evaluations that we do, we conduct rigorous research involving clinical trials with refugees. So instead of simply documenting trauma, our research focuses on what happens to people after they arrive in the US and other developed countries. So my research, for example, focuses on chronic pain in refugee torture survivors. We're aiming to not just document that torture has occurred or that people are fleeing war violence or persecution and coming to the US and what happened to them in their home countries or on their migration journey, but really looking at how we might be able to establish the highest standard of care in medicine for this population. What we would want to do for a traumatized individual who has experienced psychological violence or mental health trauma or sexual violence in the US, how might we be able to do the same for immigrant refugee populations? Of course, in the context of COVID, we really had to pause some of that research and are just getting it started up again. Another project with the Harvard FXB Center for Health and Human Rights looks to decrease violence against women and young girls in Greece, decreasing trafficking in refugee camps. It's obviously an issue that is quite complex, but doing rigorous research, using a format of clinical trials and evaluation, can we understand the problem and hope to find solutions? So I think what we're trying to do, these are really complicated issues. Our goal here is to share with you what our work with immigrants and migrants looks like between the Cornell Law School, Weill Cornell Medicine, and the tech campus, the Department of Communications, people that are working together, this transdisciplinary project, working with students, from the medical students, law students, graduate students, bringing people together, bringing different expertise together to try to tackle some of these problems. And I hope that we've been able to give you a sense of that. So Steve is briefly going to go into what you can do to get involved or help if you're interested.
There's a lot that you can do. You can help us with our research project regarding the impact of new public benefits restrictions on immigrants. You can help us, if you're a medical doctor, for example, serve as an expert witness in litigation to release immigrants from detention. For example, Gunisha and I are working right now on behalf of a Cuban doctor who's detained in Arizona. She came to our attention through the Cornell Law School Asylum Clinic, and she told us when she got detained in Arizona that she thought that detention center was a hotbed of potential COVID outbreaks. And indeed it did. Over 200 people in that detention center, including herself, became subject to the coronavirus. She was very sick for a while, and we're trying to get her out. The medical school and the law school are collaborating on different ways, both litigation and advocacy, to try to get her out. And so if you're a doctor listening to this, you can help us with your expert views on that. You can also participate if you're at Weill Cornell in the Weill Cornell Center for Human Rights. And again, public advocacy and education is important. And so helping us write op-eds or articles about these very complex issues and trying to break them down for the general public can be very important. Gunisha and I were just talking today about writing an op-ed about some of the confusion and anxiety caused by these various immigration restrictions. With that, let's turn it to questions and answers. And if you have any further questions that we don't answer today, you can email either of us. You can also look to the Migrations Initiative website at cornell.edu, at the Weill Cornell Human Rights one. And I forgot to put up the Migration and Human Rights website at the Cornell Law School. We'll also have a PDF of our slide deck and a recording that will be available after the webinar. With that, I'll turn it back over to you, Eleanor, and you can moderate the questions.
Great, thanks to you both so much for this talk. And I'm just going to remind the audience that we're taking questions through the Q&A button. I see a couple coming through already. You're welcome to post them there, and I'll share them with the speakers so that we can get the discussion going. So I'm Eleanor, a postdoc with the Migrations Initiative, and I also have the pleasure of working closely with Steve and Gunisha on our migrations projects here at Cornell. And it's really interesting to hear you talk about your work. It always is. It's been, I guess, maybe a couple of months since I've heard you present this, so it's interesting to see how things have changed already over time a little bit. And I wonder if I might get the conversation started by asking you to think a little bit about or share with us how your research project has changed, if it has, over the last few months because of the pandemic. I mean, it seems to me like you had this project in place that was already pre-pandemic, very focused on questions of access and tech potential, and that's only more clearly important right now. But I wonder how the pandemic has made you rethink some of what you're working on.
Gunisha, why don't you start?
Sure. So I think, Eleanor, exactly what you're saying. This is something that we thought was a critical issue pre-pandemic. And what the pandemic has really done is revealed how critical it is and how important it is at this time. What we're seeing in these immigrant communities and refugee populations is so far beyond what we see in the general population. I'll give you an example. At Weill Cornell Medicine, I was part of the COVID airway team, which meant that I, intubated people from March, April, May, pretty consistently, people who were coming in with severe COVID illness, needed to be placed on a ventilator, needed to be intubated. The family members of those individuals, we gave them really good information about how to protect themselves, restrictions on coming into the hospital, and it wasn't all smooth. It was a learning experience for everybody. But what I was able to convey to those patients about hand hygiene or social distancing, to those family members about how to not become ill, it is completely different. I mean, really, we can't even compare it to what we saw and experienced in refugee camps, for example. I was in Moria in Greece in December, and what we saw there was a camp of about 40 or 50,000 people in a space that was made for a few thousand people. And those individuals have no access to running water. They live in open air tents. When it snows, they're sleeping on the snow. So how do you protect those individuals? How do they socially distance? How do they wash their hands? When they don't have access to a shower for 2 weeks, how do we say, wash your hands, don't touch your baby, don't, if you're sick, separate from your family? It's completely unrealistic. And when we talk about the impact of COVID on those communities, we can't even measure it. How can I look at what the death rates are of COVID in those vulnerable populations when I can't even account for it? I don't know. Every day at Weill Cornell, I get an understanding, an update from the administration. How many COVID patients do we have? I know that we did our first intubation on what day, when did it end? We don't have a sense of that in these smaller populations, in these refugee communities, in these vulnerable populations. And so that, I think, has really brought an urgency to the work and an urgency to the research that was already there, but it has just really amplified it. I say that before COVID hit, I felt like I was working at 250% capacity. And now I think it's just off the charts. I don't even know how to measure it because it just feels, I feel like I'm thinking constantly about how we might be able to get people to pay attention, have people understand that no matter what field you're in, you can contribute to this, you can make it better. And I think Steve probably echoes that urgency.
Yeah, for example, in upstate New York, over half of all farm workers are undocumented immigrants from other countries. And they were always worried about, being picked up by immigration. It was very hard for them to get off the farm, to go to a grocery store on their 1 day a week, because they were worried that the New York State Police might pull them over if they had a broken taillight and then turn them into ICE because of that. Then COVID hit. And then on the one hand, they were deemed to be essential workers. On the other hand, they were even more at risk, both because of getting COVID and still being picked up by immigration. So the Cornell Farm Worker Program has done a phenomenal job of trying to educate farm workers and also farmers who employ them on the COVID situation, but it's been very hard. The Cornell Farm Worker Program has set up a WeChat, for example, with 3,000 farm workers on it, where they can get essential information out to the farm workers. They also have set up calls with a doctor who speaks Spanish to try to understand some of the healthcare needs of farm workers. But the underlying problems that undocumented farm workers had before COVID have only been amplified and aggravated because of the coronavirus pandemic.
And could I ask you also to speak a little bit more about what those dynamics mean for people who are in detention? So I was thinking about this, Gunisha, while you were talking about the situation in Moria. And I wonder, things have changed over the last few months at the US-Mexico border a little bit. You mentioned, Steve, the case that you're working on. I wonder if you could say a little bit more about what people are facing who are in detention right now.
Yeah, it's always been hard for immigrants who are in detention to be able to pursue their legal rights. For example, they may have a fear of persecution, but if you're in detention, you may not be able to get a lawyer. Many of these detention centers are very remote areas. Here at the Cornell Asylum Clinic, we're fortunate enough to be able to help a few immigrants appeal their asylum decisions, but we can only help a few, and there are up to 50,000 people detained any one night on average in the United States who are immigrants, not necessarily because they committed any crimes, but simply because they crossed the border and have applied for asylum. And coronavirus has made that situation even worse. I can't send my students into detention centers now to be able to interview our clients to find out the bases for their fear. We can only write letters, and that takes much longer time. Even phone calls is much harder because many of the detention staff have gotten sick, and so they're understaffed. And so it's very hard to get detainees to the phones to be able to talk with us. And then there's the whole concern with actually catching coronavirus in these facilities, the lack of transparency by ICE, not telling detainees or even their own staff, of the fact that there's an outbreak in these detention centers. So it's really been an incredible anxiety-producing impact for these detainees. And I know that some detainees who don't have, good lawyers to represent them simply given up, given the combination of being detained for long periods of time and not having the lawyers. And that's what this administration wants, is to be able to deter others from coming. And we haven't even gotten into the fact that this administration has used the pandemic as an excuse to prevent people from even coming to the United States, not under immigration law, but under public health law, claiming that it's an emergency to stop people from entering. So over 150,000 people have been prevented from even entering the United States to apply for asylum since these orders have come out.
Thanks. And I think at least a couple of months ago, there were also some news stories about people who are being deported who are COVID positive as well. So blocked people from coming in, but also spread the virus to other countries through these deportations.
Unfortunately, that has happened. We've sent people who have been COVID positive back to their home country without telling their receiving country that they were COVID positive. And so we're spreading the disease both ways, both in detention centers and back to people's home countries.
I'm going to take a question from the audience. Someone's asking for more insights on the geographical limitations to your study and information on possible support for replicating similar studies in other regions or countries.
Well, our first study,
Sure, so
go ahead, Gunisha.
No, go ahead.
So our study right now is limited to patients at Weill Cornell. That's what we got funding for. But certainly in the digital communications aspect of our study, when we're trying to figure out ways to take the information that we learned from our study and spread it out into the immigrant community, we're trying to find out good ways that work not just for those patients, but more generally. And so a research assistant and I at the law school, for example, have interviewed immigration nonprofits around the country as to how they communicate with immigrant populations. And it seems to be a variety of different ways, depending on the type of immigrant community. For example, for farm workers in upstate New York, WeChat seems to work well. In other parts of the country, radio plays in Spanish work well. In other parts of the country, depending on the community, it may be that you go to trusted third parties like ministers at churches to get the word out to immigrant populations. So our particular research project is currently geographically limited to New York City, But, you know, if it works out well, if we can get more funding, we hope to take it national. Gunisha?
Yeah, I echo that. I mean, I think the study is itself based at the Center for Human Rights, but the reach we hope will be beyond that. The digital aspect of it really does allow us to expand beyond, and this research is quite complex no matter where we do it. For example, we have an on-call bioethicist that we work with very closely at the medical school, because research in human rights is so complex and so ethically challenging. When an individual comes and says, you know, can you guarantee me that ICE is not, if I participate in the study, that ICE is not going to come for me at, you know, the clinic where you're interviewing me, can I guarantee that? I really can't. And so we have to, our consent forms, for example, are 16 pages long, but then that becomes very complicated when you're dealing with a population that may not speak English. So do you really translate all those consent forms? So these are the types of questions that we run everything by our bioethicist. But the Center for Human Rights and my research lab at Cornell, at Weill Cornell, we've done clinical trials for many, many years now. And I think we have such a good relationship with our clients here. We have faculty who are very experienced with this population. So that helps us really do this in an ethical and a responsible way. It's not easy. Adding COVID to that makes it even more challenging. For example, those issues of telemedicine in this population. Now we have to do research with telemedicine. It's even more complicated. But we're making good progress, and I hope that the impact of this will be quite broad, and that we'll be able to get good data over the next year.
Great, thanks. And I wonder, I guess, I'm reading a little bit into this question, but I wonder if you're able or willing to speculate a little bit on how some of the dynamics that you're studying might be different for somebody who's trying to do a similar study in a different region of the US or maybe in a different country. So what parts of the study that you're working on are especially specific to where we are? Or is that maybe not a valid question at this?
You mean New York City, or?
Yeah, to New York City or New York State.
So we hope none of it. We hope none of it is specific to New York City or New York State. I mean, the client population from which we're pulling is truly globally representative. And our study design allows for enrollment that accounts for the global representation, right? So we're not just looking at people from, for example, Central or South America that have experienced gang violence. We're not just looking at people from West Africa who may have experienced persecution due to sexual orientation. We're really looking at people from all over the world. And while the population from which we're drawing is a New York City population from that clinic, the clinic itself is globally representative. And I think if there's any place to do a study that applies to other regions, it's New York City is such a great place. We're considering all of those aspects of how does someone's country of origin, their social background, the political background, how does that influence some of our these outcomes? How does that influence how they engage in healthcare, for example, or how they engage with technology? But what we're finding is that there's good data to support that some of it is quite consistent. So for example, migrant populations tend to have smartphones or phones with them, mobile technology. So we are able to, and we're using data that's from developed nations and other studies around HIV or maternal child health from developed countries to inform the design of our own studies so that we'll be able to apply it to a global population.
Thanks. I think we've just gotten a question that is picking up on some of what you've just said, and I'll pose it to both of you. From Abdullah Ridwan, what are some of the specific ways that the center is increasing technology access? Maybe if you could share a couple of examples of the resources that you're thinking about developing, and how can the integration of technology be expanded to help the center with its mission? And then there's a follow-up point but I'll ask you to respond to that one first.
Well, it's a two-way street. We're doing research to find out what immigrant populations generally do to find out information. And so, for example, as I mentioned, we found out that many immigrants have smartphones. They may not have access to a computer, but at least they have access to a phone. And so applications like WeChat and others may be one way to get information out to immigrants, and in turn, they can send questions in to healthcare providers or others. But I said it's a two-way street because we're also using the study to find out from them as to how they get information that they deem to be reliable. And so our survey questions are not just on healthcare issues, but also on technology usage. And as we start to develop the technology that we hope will work, we'll certainly incorporate the immigrants themselves to try to make sure that it's user-friendly, it's in multiple languages, et cetera. So I can't say that's going to be one size fits all. I think for some populations, doing a presentation at a church may be more effective than trying to, do a WeChat with them. So I think it's a complex area, and I think that we'll have different solutions for different types of immigrant populations. Gunisha?
What I would just quickly add to that is that this is why we have pulled in people who are experts at communication and technology. As a physician and a human rights researcher, I don't know that I have the best answer to that. Steve, as a lawyer and a professor, we don't know this space that well. And so that's where the multidisciplinary nature of this project, it really truly is. We very strongly defer to our tech and communication experts on whether a website is more responsible, is an app more responsible, do people feel like they're being tracked by apps? I don't know the answer to that. I can tell you when you're pregnant how many visits you should do as prenatal visits, and Steve can tell you what you're entitled to in terms of public benefits, but we need a tech expert, and that's what we have. And I think that's the beauty of the Migrations Initiative. It's the beauty of these collaborative projects, that we're able to weave together this expertise and come up with something that's so far beyond what we would be able to do individually. There's no way I could do this project on my own. And I think that really, we have so much wonderful expertise at Cornell and beyond, and the ability to work together collaboratively will hopefully result in work product and assistance for these individuals that's far greater than what we'd be able to do alone.
Thanks. I'm going to turn back to the question of public charge that you went over. And we have a question here that is asking maybe about tracing, maybe broader, from Sid Taro. What are the implications of the public charge rule for surveillance?
I'm not quite sure what Sid means by surveillance. It could mean two things that I'm aware of. One is like contact tracing. And that should not be a concern. The confusing guidance that the immigration agency came out with about immigrants being able to get tested for COVID without worrying about public charge, that part still stands. And so I think getting contact traced should generally be okay. But as Gunisha pointed out in her part of the presentation, if the contact tracing is done by police officers, that's certainly going to scare immigrants. And we certainly need to make sure that police officers, if they're doing the contact tracing, are trained that they should not be using that as a subterfuge for immigration enforcement. So I think we need to do more education of police and the public generally about contact tracing. In terms of surveillance generally, the public charge rule itself doesn't include any of that, but the immigration agency has just come out with a proposed rule to collect more biometric information from all immigrants, whether they're rich or poor, no matter what stage of the immigration process that they're in. And if that rule becomes final and goes into effect, that could have a significant impact on making the immigration easier, making the immigration agency more easily available to surveil immigrants on where they are at all times. So that is a concern, but it's not directly affected to public charge per se.
And another question about the public charge rule coming from Wendy Wolford. How does the new public charge rule compare to rules regarding public benefits in migrants in other countries?
I'll start, and Gunisha may know a little bit about this from refugee camps, but as far as I know, America is a leader for good or for bad. And as we impose more restrictions on immigrants in the United States, other countries pick up on that and also start to impose more restrictions. I don't know the equivalent public charge rules in other countries. I know that to our north, Canada still is fairly liberal in terms of the public benefits that its immigrants can receive in that country, but I don't know about other countries. I think that stepping back, if we think about what the purpose of bringing immigrants or refugees to the United States is that we want them to feel welcome. We want to integrate them into our society. And so limiting them from public benefits, I think, does a disservice both to the immigrants and to the nation, and that it retards their ability to be able to acclimate to this new culture that they are now living in. So I think that we need to know more about some of the broader aspects of limiting public benefits on immigrants. But I suspect, for example, that more immigrants are having to go to the emergency room because of the restrictions on public benefits than if we didn't have these restrictions and they were able to talk to their doctors about problems before they became serious enough that they had to go to the emergency departments. Gunisha?
Right, I think, I don't know how the public charge rule, if by law, is similar or different in different countries, but the impact of the law or the rule, here it's so clear that it's beyond what the rule actually is, that millions of immigrants are disenrolling from public benefits, and that it's creating this anti-immigrant rhetoric. And I think that we know is mirrored in other countries, like Steve is saying. So in Greece, for example, how the border has become so much more militarized, and the move to block migrants from coming has become increasingly violent. Like Steve is saying, I think that comes from, the inspiration for that may come from our reaction to immigrants and things like the public charge rule. So, you know, I wish we had a very clear understanding of what the public charge rule did and how people were benefiting or using public benefits in other areas. But I think the anti-immigrant rhetoric is pretty consistent throughout these different areas, and that is doing substantial damage psychologically and physically in terms of stress to these populations.
Thanks. I'm thinking back about some of what you presented about the narratives that circulate and how these fluctuate over time and the devastating effects that they can have on individuals and communities. And I know, Steve, I know you're giving a talk on the election on Monday, so I'm not going to ask you to give away any spoilers. But we're in this moment where the pandemic and the upcoming election are really, you know, it's quite a moment. And I wondered if you'd be willing to just share a couple of thoughts on, given that the election is coming, how might we think about what may or may not change for immigrants in the coming months? And if you want to tie that more specifically into questions of the public charge rule, that's fine, or if you wanted to say something more general.
Yeah, it's been a tough 3.5 years for immigrants generally in this administration. And, you know, even if Biden wins the election, he's going to have so many things on his plate: the coronavirus, the economy, relations with China, et cetera, that even though immigration is one of those important issues, it's going to be very hard for any administration to immediately undo the damage that President Trump has done on immigration. So immigrants will have to, you know, bear the weight of some of these restrictions. They cannot expect that on January 20th, the public charge rule is going to go away and all the other restrictions that have happened. And that causes more anxiety and confusion. We're seeing that just in terms of fewer people coming to the United States, either as tourists or as international students. We see it in terms of the decrease in the number of people applying for green cards. We see an increase in the number of people applying to become naturalized US citizens so that they do not any longer have the fear of deportation over the public charge rule or anything else. So I think that on the one hand, everybody hopes that the election will change things and make the next administration more immigrant friendly. But I want to caution everyone that it is not going to be a panacea, and that it's not going to be something that happens on day one of the administration. So we may spend the next 3.5 years digging out from all of the immigrant restrictions that this administration has imposed. So.
Yeah, I think even beyond that, the sustained impact of some of these policies in terms of, for example, Steve would know this better than I do, but judges that are now making decisions about what happens. You know, I think that that's not going away, no matter what the outcome of the election is. I know my my own brother, who's was in law school a few years ago, had quite a life-changing experience in a grocery store when somebody started yelling racial slurs at him, and it has changed his career trajectory and life course. I think for a lot of us, it has in a positive way. We've shifted our work to really add the pressure to fixing some of these issues and contributing whatever we can. But everybody is quite charged from both sides, and I think that that's not going to go away.
One other thing I think people need to realize is that if a new president, does try to do something that's pro-immigrant, he or she may well be sued by anti-immigrant organizations, just as the ACLU and others have tried to stop anti-immigrant initiatives by this administration. You may see conservative states like Texas or others try to stop any pro-immigrant initiatives that Congress or the agencies take in the next administration if we have a different president. So I don't want to be too pessimistic, but we're in a deep hole and it's going to take a long time to get out of it.
And even some of, sorry to, Steve and I are just going to keep going back and forth. You can't fix a breakdown in trust or psychological trauma that's caused just because let's say there's a new administration that comes in. It doesn't mean that all of a sudden people feel security and comfort in those naturalization papers, or they feel that they can re-enter the system. Trauma, we know, for example, from family separation at the border, if somebody's been separated, that's generational trauma. That's not just there for 2 years or 5 years or 8 years or whatever. That's decades of trauma that has now been imposed on a family. When you consider that half of the refugee population is children under the age of 18, that multi-generational impact is real. And I think we're going to have to, whatever we're doing right now to sort of stop the bleeding, and really just hold down the fort and provide support to these individuals, it's going to flip into a whole new layer and a whole new sphere of care for these individuals, rehabilitation, restitution, providing reparations and creating a safe environment and space. And that is, I think we're looking at 20, 30, 40, 50 years of work ahead of us.
Thanks to both of you. We have a question from Braden Preston, who's a student in the migrations course. Do you know of any studies on how migrant worker securities or protections have impacted overall economic productivity? Do the benefits given to immigrants generate any net positive stimulus, or are they seen as not being beneficial? This may also, at least when I read it, I connect it also to some of the narratives that circulate about why immigrants come and yeah, the impact of that.
Go ahead, Gunisha.
Well, it's such a great question. And the answer to that, I would say, is we know that immigrants provide an economic benefit. But that logic doesn't work if you're anti-immigrant, because the conversation then flips to, well, they're stealing jobs. So we've actually tried this. We talked early when family separation was happening with some folks at the border about how we might be able to say that detaining individuals is just far more expensive than letting them have work permits. And wouldn't that be a compelling argument? And it's not. If you want to be anti-immigrant, you're going to be anti-immigrant.
But
Steve,
there are studies that talk about how, you know, treating migrant workers with the same labor protections, for example, as U.S. workers can benefit both the immigrants and the U.S. workers. One of the concerns about immigrants is that, you know, they're stealing jobs, they're working for less pay than U.S. workers, they're not getting overtime like they should be, they're not getting workers' compensation. And if we had a stronger labor department with more agents to enforce existing labor laws so that all workers, whether undocumented or US citizens, were getting overtime and getting paid minimum wage, then that would lift the economic benefits for everyone involved. So part of it is not that we're giving extra benefits to immigrants, but rather that we're treating them the same as US workers and using existing labor standards laws and enforce them fairly and across the board so that everyone would benefit. So no one would feel that an immigrant is necessarily stealing a job from them. To add on to what Gunisha said, yeah, there are a lot of economic studies that say at the macroeconomic level, you know, immigrants help the US economy, but that doesn't do any good for an individual laid off US worker who thinks an immigrant has stolen his job. So you have to figure out how to reach the hearts and minds of those individuals to show them that immigrants actually are helping them. And sometimes it's through trusted third-party individuals, like their local church or a police chief who says, you know, we should be treating immigrants better because if we got more cooperation from immigrants, then we'd be able to solve more crimes more easily. When they're afraid to speak up because they think they'll be turned in, then that reduces our ability to solve crimes. So sometimes, I think somebody coined the term Bible belts and businessmen. If you had those kinds of third-party validators talking to people about the benefits of immigration, we might be able to make more headway in showing people about the benefits of immigration generally.
It also sounds like, drawing on what you've shared about your work, that we could also have that conversation about the questions of health that are coming up with the coronavirus, that immigrant health is public health. Is that fair to say? I see.
Absolutely. I mean, if I want, I've talked to Gunisha was going to add that, but definitely to the extent that, you know, immigrant workers on the front lines are not seeking, you know, coronavirus treatment or getting tested because they're worried about either the public charge rule or getting picked up and being deported because they're going to a testing center, that slows down the ability of the entire United States to get over the coronavirus pandemic. So it behooves all of us to get everyone tested, whether they're undocumented or an immigrant or US citizen, and we need to get that message out. Gunisha, do you want to add to that?
Well, I think it's so obvious that we need everybody on the same page to overcome this pandemic, and it's infuriating to see how these communities are treated. I mean, when you have early in the outbreak, you know, the law that Steve was talking about, that testing is not going to be included in public charge. When you have totally destroyed trust within a community, it's very hard to say, well, we're going to deport you, you're a public charge, we're going to separate your family at the border, but by the way, you should come in and get tested. It's just the two narratives don't match, and I think the trust has been so broken down in these communities, it's really hard to build back. And I know many people at the hospital who felt very personally charged at the idea that immigrants who contribute so much to healthcare and safety of communities, you know, would not be valued, and we're still being attacked in a way, and it's just really complicated. I think it's hard for me to dissociate my own emotion and experience at the hospital from the legally what should happen and logistically what would happen and how practically do we do this. It's just it's so obvious that we need everybody to work together, and yet we've created a system where there's just a complete lack of trust, and that's not possible anymore.
We have a question about, so Rocio Ramos is asking, what should you tell the immigrants about the forced sterilization that ICE is doing at detention centers, and what actions can they take? And I assume this is in reference to a story that's come to light about a doctor who was performing hysterectomies on immigrant women at a detention center, I believe in Georgia. I'm not sure if that's something you all are able to comment on, or if you're willing to share thoughts about what actions could be taken.
Well, I can talk from a legal perspective, and Gunisha could add from a medical perspective. I have a one-word answer from a legal perspective: sue. Everybody has basic legal rights, and these forced sterilizations should not happen in the first place. And Gunisha may be able to talk about better training of doctors who work for ICE as contractors. But from a legal perspective, if it does happen, whether they're undocumented or in detention centers or not, they have the right to sue for these kinds of invasions of their body. And indeed, already the Southern Poverty Law Center is trying to put together a litigation team to sue on this. Obviously, it'd be better if it didn't happen in the first place, if we had better training of ICE doctors, and we had more transparency as to what was happening to immigrants when they're being taken to medical visits. But in the aftermath of these particular situations, at the very least, they should sue as a deterrent for other doctors and other centers from doing the same thing. Gunisha?
Yeah, I mean, I think it is, it's quite complicated when there is that lack of transparency that Steve is saying. We don't really know what's happening with these individuals when we are not allowed to be present in detention centers. Already accessing detention centers was quite complicated, and now with COVID, it's near impossible. So you're unable to really talk to people. I'm working with the ACLU on something for an individual who's detained, and I can't even question that individual myself to get the medical information. And that's just an example of how challenging it can be to provide not medical advice, legal advice, medical legal advice together. Training physicians, I mean, I think it's painful to see a physician who might be involved in those kinds of practices. It's, to me, triggers the same feelings that I have when I see a physician that's involved in torture. In my research, people are coming in after having experienced torture, and often there may be a healthcare provider or person who has been involved in that. And especially in the community population in which I work out in Queens. And, I don't know that there's a level of training that you can provide physicians when physicians take the oath of do no harm as their first practice in medicine. I'm not sure how that gets obliterated by being a part of these other organizations, and how you might be able to return that by restoring the humanity of these individuals. I don't have a good answer to that question. I wish I did, but I really don't, unfortunately.
We have just a few more minutes, and I see one question coming in that's connected to anxiety and gender. And I also wanted to ask, you've talked a lot about that a lot of what immigrants are experiencing is not only physical, but it's all of this adds to the stress that they already experience. And so I wondered if you might be able to talk a little bit more about mental health care that is available, or ways that people are managing to create or find mental health care for immigrants and refugees. And I can also share that this question has come in about immigrants and refugees in Turkey, where the findings are that men are more anxious than women about COVID-19 among those populations. So I wonder if there's also an aspect of gender in dealing with the stress.
Sure. So I think the last clip of that question, is this an expression of the invisibility of women in migration? It's a really great question. And I think that is potentially the answer there, that marginalized communities become more marginalized, right? That's what we're seeing in COVID. Women, whatever invisibility there was around women is becoming more invisible. Mental health has always been neglected. I think those of us that do asylum evaluations and deal with refugee populations, we recognize that PTSD or depression may be a substantial component of somebody's overall health. What I have seen, at least, is either mental health gets ignored entirely, or it becomes the all-encompassing issue that this is all psychological and it's all in somebody's head. So in my research, for example, in chronic pain after torture, what we've seen is that people get diagnosed with PTSD or depression after torture or trauma, and it's entirely forgotten that they might actually experience nerve-related pain, neuropathic pain, or nociceptive pain, because mental health is thought of this completely separate category. And what people will say in those populations is that they're converting their psychological trauma into physical trauma. So it's psychosomatization of their pain, and it's not real. So that's what you experience on one hand, that it's all in people's heads and it's all this mental weight and trauma. But on the other end of the spectrum, mental health is completely ignored. What I would say is, knowing what I know from our client population with patients that I work with that are immigrants or refugees or asylum seekers, people are struggling with the basics of survival. When you look at like the hierarchy of needs, you know, people don't have housing, they don't have status, they don't have food, they don't have education. When I am able to point out to somebody, a client or a refugee, that they are, or an asylum seeker, sorry, that they may have substantial mental health or trauma, mental health issues, I don't know that people have the time to engage with it. Even physical pain, debilitating physical pain, people will say they don't have the time to see a provider or deal with it. So when you're trying to balance, you know, sending your child to school, the fear of deportation, getting them a lunch at school, where in there do you prioritize your mental health? And yes, I do think that women become particularly marginalized.
Steve, did you have anything to add about questions of stress or how these situations affect men and women differently?
No, not on the medical front. I mean, I think that there's also secondary trauma. I mean, medical providers, legal providers. I mean, we all should be taking care of ourselves as well because of the stress of both general immigration restrictions and particularly coronavirus, and caring for others who have coronavirus or are being detained. So the stress is not just immigrants, it's everyone that's affected by this.
Well, thanks to you both. I see that we're reaching time, so I'm gonna close the Q&A here, unless either of you has a last word that you wanna share with the audience. And I will thank you both, Steve Yale-Loehr and Gunisha Kaur, for really fascinating talk and really important work that you're doing. And thanks to you all in the audience. And I hope that you can join us next week also, when we'll be back here, same time, and continuing some of this conversation about the pandemic with Jen Meredith from the Public Health Program, who'll be giving a talk called Migrations and One Health: Human, Animal, and Environmental Interactions and Emerging Diseases. So thanks again to everyone, and look forward to seeing you next time.